Swedish. This week we're talking about shoulder joint replacement surgery. I am your host today, Michael Connors, and I want to encourage all of our viewers that if you have questions, feel free to enter them into the comment section and we will get to them as they come through. But I am joined today by Dr. Grant Garcia, and I'll just allow you to introduce yourself to the audience.
Hi, I'm Grant Garcia. I'm a sports and shoulder surgeon at Swedish Ballard, and I specialize in complex and regular shoulder replacements and shoulder arthritis.
All right, so to get started, we're just going to kick it off with how would you know if shoulder replacement is something that you need or should be looking into?
That's a great question. So generally patients come into the office and they're complaining of chronic pain they've had. Generally they're older than 50 years old. They start to have a loss of motion. They've usually tried therapy, injections, etc. And really it's the motion loss and the pain that gets me to start thinking, do they have some type of arthritis? Now there's many different types, but the most common one is sort of general wear and tear.
Okay, and then you had mentioned that there are different types of joint replacement surgery. What are the different types that you can get done?
So there's a number of them, but the three most common ones are a partial replacement. That's where we just replace the ball portion. And then there's a ball and socket replacement, and that's sort of called a total shoulder, an anatomic one. So we do the ball and the socket in the actual anatomy of the patient. So your ball is your ball and socket's normal. And then if you have something that's a little bit more unique or complex, we call it a reverse shoulder, where we actually switch the socket and the ball around. And that's for people that don't have a rotator cuff. So we have a lot of different options. And then there's even more subspecialty options we offer at Swedish that we can do as well.
Okay, and then what does the actual surgery entail the day of?
So day of, a patient comes in, they're checked in, etc. They go to the operating room. Generally what we do is we do a muscle sparing approach, so we do muscle splitting. We go in there, we see the two arthritic parts. One is the ball and one is the socket. We actually remove those with a saw and clean them up. And then what we do is we implant in these implants, and usually we don't have to use any cement or anything for a lot of the options that we have. So these are press fit and they grow into the bone. For total shoulders, there's a plastic piece that we have to cement in, but part of it does actually ingrow, so it's some pretty cool and interesting things.
Now, you had mentioned arthritis. Could you just go into what that is and what is actually causing the pain in the person's shoulder?
That's a good question. So if you think about a chicken bone, you can see there's that white, nice cartilage you see maybe at Thanksgiving or something when you're carving a turkey or chicken. But that white cartilage starts to wear down, and that's what we call arthritis. And when the cartilage itself is not painful, but the bone underneath gets very painful. And there's a lot of nerve endings in that bone. So as you start to wear it down, you have bone on bone, we call it. You start to have some changes as well, so the bone gets angry and grows more bone around it. And you get that loss of motion. That stiffness is painful, plus the exposed bone is quite painful as well. So that's really what arthritis is in a nutshell.
So other than living with that pain, are there other downsides to postponing your surgery?
This is actually a good question and a topic we can bring up later. But the downside to postponing a shoulder replacement, at least 20 years ago, people were worried about the longevity of these implants. But I find that most of the patients actually postpone them longer than they need to and suffer longer than they need to because they've heard sort of negative publicity on shoulder replacements. We found the data has demonstrated they last just as long as knee and hip replacements. It's just that there's not as many of them out there, and so people tend to have more blog connotations online and everything else you hear now with Google.
Now, you had said that they last as long as knee or hip replacements. How long is that for someone that doesn't know?
Okay. So we're seeing at 10 years 90%, so that means that of 10 people that do it, only one person has to have some type of change in their shoulder replacement. It doesn't even mean a full revision. And then we're seeing around 85% at 15 years and 80% at 20 years. And again, that's 20-year-old data with the older implants. The newer stuff that we're using, which is in the last 4 or 5 years, is supposed to last even longer with different implants and different structuring of the shoulder. So we're pretty excited about the future.
Now, someone that does go through with the implant, and I don't know if it varies based on whether it's the reverse or the normal, but are you going to be aware of the implant in your shoulder post-surgery?
The answer to the question is twofold. One, the answer is yes, you will be aware of the shoulder replacement. You always know you had some type of replacement. It depends on the type, so the reverse is not really anatomic, so it feels a little different. You take some time for your new muscles to learn. With the anatomic one, or the one that's sort of the natural shoulder replacement, they learn pretty quickly, and they do say that they do feel a difference, but generally these patients are in so much pain, and the improvement is so drastic and satisfaction is so high from it that abnormality of feeling their shoulder is different. It's really just because they've never felt pain-free for like 10 to 15 years.
Okay, so that's a good feeling to have
Yes.
then, definitely. So if someone is having, say, problems in their left or right shoulder, is that going to lead to, or does that usually lead to problems in their other shoulder?
That's a good question, and it's actually not so clear-cut, and we don't really know the data because some part of it's genetic, and that's sort of the ones that are kind of, their parents had arthritis and now they have arthritis, or they develop it in their knees and then they got it in their shoulders. So I would say of my patients, about 30% have bilateral, but just because you have arthritis in your shoulder doesn't mean you need a shoulder replacement. We treat symptoms, not patients. And so the important thing there is to understand that just because you have one side needs to be done, you might not have it on the other side, or you might not need anything on the other side.
Now, are there certain activities that bring on arthritis, or say you already have arthritis, things you should be cognizant of what you're doing to stop furthering the issue?
That's a really good question. So that comes into the difference of what types of arthritis patients have. So there's the general arthritis, that's the one natural wear and tear, poor genes from overall genetics, et cetera. And then there's the sort of post-traumatic. So people have had either a previous fracture they've had fixed. We do those replacements for those type of patients. The other one that's the most common, and one of the most common pathologies that I see as a shoulder surgeon, is people who have dislocated their shoulder. And generally they're the patients that are a little bit younger, more in their early 50s or late 40s, that have had recurrent dislocations of their shoulder, and they need to have the replacement done. Those are the two main ones. There's rheumatoid arthritis, but that's really improved significantly with new medications. So the most common one we see are those post-traumatic injuries.
So so the viewer is clear, are there options available to ease the pain that aren't surgical?
Yes, I mean, we usually do an extensive line of treatments at Swedish for this. So the first thing we start with, obviously, is conservative management. We evaluate the patient. We want them to start doing exercises, stretching, et cetera. That's the first step. Second step is cortisone injections. And, really, I don't really have a limit in terms of the number of cortisone injections I'll do for someone with arthritis, but generally it's 1 to 2 cortisone injections. And some patients get one cortisone injection each year and can last around 10 years. Some patients come into me and they get one cortisone injection, it lasts for 2-3 days, and we have to proceed with the next steps. And then there's less proven data on sort of gel shots and PRP. Those are some things that we do a lot in the knee, et cetera. We don't really do that as much in shoulder, but that's something to even think about, especially if you're younger and you want to prolong it as long as possible. The last option is we do something that's more in the sort of sports realm, but shoulder arthroscopy. So if there's someone's younger, these are mainly for patients that are under 60 years old. We can take some of those little bony areas that are worn down and actually clean them up with the scope, clean up the cartilage debris. And if you do the specifically in properly selected patients, it actually works quite well. And we can prolong someone that's, say, 55 to 60, 65 years old. When they have a shoulder replacement, then it's their last replacement.
Well, thank you. So we actually got our first question from the Facebook audience. So I want to thank Ellen for participating and encourage anyone else out there that does have questions, feel free to submit them in. But she asked, is this procedure inpatient or outpatient?
It depends, and that's really, at Swedish we can do it both inpatient and outpatient. I like most of my patients to try to go home within that day or the next day, but you can safely, if you don't have a lot of medical problems, you can go home the same day. And we have a lot of excellent anesthesiologists here at Swedish that do pain catheters, and almost all my patients get a 3-day pain catheter, and a lot of them are able to go home.
And then Heather also, thank you for your question, and it kind of ties into that one, but
Perfect.
what is the expected recovery time on shoulder surgery? So you'd mentioned leaving the hospital possibly day of, but then I guess after that.
Well, that's an excellent question. So for my patients and for patients at Swedish in general, usually we're in a sling for 4 to 6 weeks, and that really protects the rotator cuff muscle that we repair in the front. If that wasn't the issue, you could be out of the sling much quicker. But generally, it's 4 to 6 weeks in the sling. You're starting physical therapy within 2 weeks to try to get your motion back. I would say most patients around 3 months are quite happy. The pain relief is pretty dramatic, so in terms of how they feel, usually 2 to 3 weeks. And I'd say 4.5 months or so, most patients, depends on the type of implant we use. If it's an anatomic shoulder, we're getting almost all the way up here. Reverse shoulder, which is for more complex issues, we're getting about here, and they're feeling that relief and having that relief around 3.5 to 4.5 months.
Following up on that then, so what does physical therapy for this look like?
Excellent question. So for physical therapy, generally starts off with some passive motion because we're trying to protect the rotator cuff muscle that we repaired in order to do this surgery. In addition, we're trying to start to slowly rehab the patient without having to cause any more further edema or pain. So usually it started passive, like the physical therapist and you were working on stretching, And then usually within a few weeks, we start working on strengthening, so starting bands and other stretching exercises. We find that the therapy is important, but there are some studies, especially with some of the reverse shoulder replacement options, that show that physical therapy is important, but really patients will still do well even with minimal therapy.
Thank you. So next question I had, you had mentioned that it's generally older populations, but is there certain people that are more at risk? Is it prior athletes, or is there something from your past that might be, you want to be cognizant of that you're doing now that might lead to problems in the future?
I think you're doing an excellent job of asking questions, and you're really getting the complexity of shoulder replacement and shoulder arthritis. So there's sort of the patients who sort of get arthritis from a dislocation, et cetera, there's two types. There's sort of like the weightlifter shoulder, and these are the patients that actually they're much more challenging to deal with because they're like and for Swedish, they're 50-year-old patients that are doing a lot of weights, heavy weights, and eventually wear down the socket. And there's the patients that sort of genetically are predisposed to this, and they're generally in their late 60s, et cetera. And that's sort of unfortunately just bad luck and genes, which we can't control, but we can try to control the symptoms to try to prolong anything as needed.
And then is it possible, or is it at all common to see it in younger populations, say under 40, under 30?
I have seen it in that, and that's generally a lot less common category, but you're doing an excellent job of going through all the different categories. Someone called vascular necrosis, so people that have had sickle cell disease, people that have had bad injuries like a further dislocation of their shoulder that was there for a while. Sometimes we have to do the shoulder replacement because other procedures are not as effective. It's one of the most effective shoulder procedures that we do in the country, and I have a lot of satisfied patients overall, but overall for Swedish, the most satisfied patients I would say for shoulder are these shoulder replacement patients.
So Ellen has another question, and she asks, for the athletes that get the shoulder surgery done, are they able to get back to their peak performance after, or are they not able to reach their optimal performance level?
That's a great question. So for shoulder surgery in general, we have pretty high results now with return to sport. The data actually on return to sport after shoulder replacements is relatively new. Now, most patients are not. For Seattle, people are generally very active, so I call them all recreational athletes. And as a result, we're seeing around 90% return to sport. But generally, it's not football, baseball, those types of sports, but swimming, golf, tennis, the normal daily activities you want to do, hiking, especially for the Pacific Northwest. It's a very high return to sport, and generally that's why I try to encourage patients that have sort of put it off for so long to try to get back to their activity level.
Okay, and then another concern people may have is after having this shoulder surgery, how long are they going to be out of work from it? How long will they be laid up?
That's a good question. So it kind of depends on the patient's job. If they're mostly at desk work, I say most patients are actually back within a week or so. The full return to work data demonstrates around 6 weeks, but that's all comers. So you have those guys that lift weights or the laborers that come into me from injury on the job that have been constant wear and tear. It may take them 6 to 8 weeks to get back to their job, but they're lifting 50 to 100 pounds. If you want to sit at a desk, generally 1 week or 2 weeks. So we'll do it, at Swedish, we'll do it on a Thursday, and maybe the following week you'll be back to work. It's pretty impressive. Now, not everyone's the same. Again, that's just an average, but overall, that's what I would expect if I were a patient.
Okay, and then if someone does decide to move forward with surgery, what are the success rates looking like?
So the success rates are similar to the longevity. So it's one of the most, of all the surgeries that we do as shoulder surgeons, it's probably the highest satisfaction rate and the highest sort of success rate, because you're basically taking someone that's got a pain level of 6, 8, 10 all the time, you're removing that joint, and you have a quick recovery. So I would say it's very high. Satisfaction rates are up to 95% for this type of surgery. Again, it's really important that you have a shoulder surgeon do this surgery. This is not one of those surgeries that is performed by a lot of different people. There's certain specifics to this surgery that are needed in order to continue to balance the shoulder and get these type of results. But we're seeing, again, satisfaction rates up in the 95%. The longevity scores that I gave you, the 90% at 10 and 80% at 20 years, that's even people that needed another surgery, not even ones that weren't just very satisfied. So we're talking about satisfaction rates in the 90% at 10, 15 years. So it's really, personally, in Swedish, it's a very successful surgery, and we like doing it to make patients better.
So you had mentioned that someone who has added 9, does it usually completely eliminate it, or does it lower it down to like a 2 or a 3?
Generally, we're seeing patients with 9, 10s go to probably maybe 1 or 2. And that's not because there's an issue or we can't get them to 0, but sometimes they've compensated in other areas, so they've developed neck pain or back pain, so we can't really address that initially. Now again, year 2 you're asking about, that's maybe a 2 at a year, but 1 to 2 years out, they start compensating better, they're back to all their sports, they're happier, they get all these other things back, and so I find that those That's why we really can't judge full pain scores until 2 years out. And at 2 years out, they continue to improve. So I'm saying even that person that's a 2 you're talking about at 6 months to a year is probably back down to a 1 to a 0 by 2 years.
Now, if someone that has a shoulder replaced 10 years down the line, are they able to get it replaced again?
They are. It's more complex, and this is even another reason why you'd want to make sure you go to a properly trained shoulder surgeon. But the answer is you can get it replaced. If you have an anatomic shoulder, generally you need it. If you need some major work done, we turn that into a reverse, since that's sort of the more reliable, more complex option for these patients. So you can have revisions. Generally, we try to avoid having to have a patient have a revision, so that's why we have these newer tools at Swedish with 3D planning and balancing, et cetera, that are really important and that are going to improve the longevity of these implants, so you never have to have that. But if you do, there are ways to do it. It adds a little more complexity, but it's definitely feasible.
So what are some of the other benefits other than longevity that this new technology has introduced to the field?
Well, longevity, and then also just naturally increasing the satisfaction scores. So, shoulder replacements, especially the socket's very small. It's much different than a knee or a hip. There's a lot less room for error. And so if the implant's put in properly, you not only have that shorter longevity, someone's shoulder replacement put in properly can only last 2 to 3 years, which seems quite alarming. And so this new technology we offer here to allow you to do 3D planning, print out guides, those type of things will reduce that, because again, you have well-balanced shoulders. And most of the time we're going into the operating room, we already know what implants we're going to use. We've already planned the whole case, and any larger things that do occur or any changes that need to happen, we're already we're expecting those things, or at least having a good sense of it beforehand. It's definitely improved a lot of what we do.
Now, Heather also wanted us to touch on the complications with this shoulder surgery. So let's just start with the short-term complications.
Okay.
What are some of the things that can arise?
Good questions. So it sort of depends on the implant you use. Let's go with the most common one, which is the anatomic. That's the one where you have your socket is kept, you have a different new socket, new ball, not the reverse. Complications are pretty low. We're talking about 5%. Again, there's always a risk of, the most common one I think is, like, we all call complications different things, but one is stiffness. Again, that's why we try to get our patients moving as quickly as possible. 2, there's always a risk of nerve injury, but that's less than 1%, and generally very uncommon, especially with well-trained surgeons. There's always a risk of infection, which is why we try to make sure that after your implant, we have different types of prophylaxis when you get dental work done, et cetera. It's similar to a hip or knee joint, and those are also potential complications. Now, while that's not short-term for the dental stuff, it's still an infection risk that occurs, and that's less than 1% as well. And if that does occur, we do have other protocols to take care of that. Doesn't mean you need a revision surgery. So those are the 3 main ones. There's always a risk of other injuries as well, but most of those are less than 1%. I'd say 5% is the stiffness, and generally the stiffness doesn't even need a surgical procedure. It's maybe more focused visits, trying to get a little more work. Occasionally, occasionally extra physical therapy is needed.
And then are there other long-term complications that can arise from a shoulder replacement?
So those long-term complications are what attribute for that 10% that don't last past 10 years. The most common complication with anatomic, that's the ball in the socket, is that the glenoid or the socket wears out or starts to get loose, which is why there's more and more companies trying to figure out ways to make those last longer and have a way where they ingrows as well as you can cement it in at the same point. And this is, again, the purpose I'm telling you at Swedish and why we have all this planning software, because if it's perfectly balanced, generally that reduces the overall complication rate from that. And that's the most common reason. You can always get an infection occasionally. I've seen this in cases, or we've seen this at Swedish in cases where someone has an illness, et cetera, it can seed to the joint itself, but those are very, very uncommon. And the final complication is if someone falls and breaks below the implant, and now you have a metal implant in, that's not going to break, but the area of bone below that is softer, and so as a result, that could be a complication. And we address that either with a revision or with plates and screws.
All right, well, thank you. And now we understand that everyone's recovery process is different, but could you just touch on the full scope of how you deal with the pain management post-surgery?
That's an excellent question. Well, this is a perfect example of how Swedish does an excellent job with this. So our anesthesiologists here usually, first off, we start off in the operating room. You're getting general anesthesia through a tube, and then you've had a pain catheter placed. So we use that for 3 days. It's called a Q pump, and it's extremely effective. It reduces the narcotics significantly. There's no need for any post-operative Foley's or any type of other issues, and that's why patients are able to leave so much sooner, because they're having this sort of pain medication infused into their shoulder to help them with reduced pain. After that, they're in narcotics maybe for a day or two. I would say that majority of patients are not taking narcotics at all, or if very light amounts. And generally they switch to sort of anti-inflammatories, which is a pretty low level of pain control. Again, like I mentioned before, for shoulder surgeons, this is probably one of the most effective, and patients are the most satisfied after this surgery. So as a result, we're finding that. Now, generally in the younger males, those athletic patients, they're a little bit stiffer and they have a little bit longer pain course. So usually the catheter is not enough to get them through for the next 2 or 3 weeks. So they do need narcotic medication. But generally after 1 to 2 weeks, you're off all pain medication.
Wonderful. So say someone has listened to this conversation, they want to maybe get the ball rolling on getting a joint replacement surgery. How can they learn more? How can they eventually get the process started? Do they have to start with their primary care, or do they call Swedish?
It just depends on each person's sort of insurance. If they can do direct referrals and go to Swedish, be evaluated by the orthopedic surgeons at that time. But for most patients, they're going to their primary care, talking about this issue they've had. A lot of patients probably know they've had some issue with their shoulder. It's stiff, you're having night pain, etc. Talk to your primary care, have them evaluate. They can do an x-ray and sort of just determine whether you have that issue. If that issue does occur, generally they'll send you to a shoulder surgeon, and that's where we start the workup of all those things I told you about.
So we're getting kind of close on time, so I want to leave it to our audience that if you do have questions that you would like answered, to do so now. But Dr. Garcia, is there anything else you want to make sure that we leave our listeners, viewers with today to come away from this with?
I would say the most common complaint I get from my patients after surgery is they wish they had done it sooner. And the reason being is, again, I told you that stigma of it being the old version of shoulder replacements did not do as well. I think patients should understand that this is a really good surgery. Now, I don't think that everyone with shoulder arthritis needs shoulder surgery, but don't suffer for 10, 15 years because you're worried about it. Again, this is a very successful surgery, and these are some of the most satisfied patients we have at Swedish.
Well, thank you again. So anyone that's listening to this post live, feel free to submit your questions in the comments, and we'll circle back with Dr. Garcia to get you those answers. In the meantime, be sure to like our Facebook page so you can get notified of our future Facebook Lives, and thank you so much for joining us today.